to the Department of Medicine Grand Rounds at the University of Rochester. Today's installation is from our Division of Cardiovascular Disease, and here to introduce the Berger Lecture and our speaker is Dr. Himabindu Vidula.
Hello, everyone, and thank you so much for joining us. On behalf of the New York chapter of the American College of Cardiology and the University of Rochester, it is a pleasure to have Dr. Ajay Kirtane with us today. But before my co-governor, Dr. Naidu, introduces Dr. Kirtane, I just wanted to say a few words about the Berger Lecture itself. So Arvilla Berger was the wife of Captain Leo Berger, a Long Island businessman. And in 1974, Captain Berger endowed this annual lecture in gratitude for the services of their cardiologist, Dr. Harold Bernstein. And the mission of the lecture is to bring outstanding cardiovascular scientists like Dr. Kirtane to New York to share their knowledge and experience with colleagues. And with that, I'll lead to my colleague, Dr. Naidu, who will introduce our speaker today.
Thank you, Hima. My name is Dr. Naidu, and it's my pleasure to introduce Ajay Kirtane, who I've known for almost 20 years now. Ajay is the director of the cardiac cath lab at Columbia University Medical Center, New York Presbyterian. And he's been there, I think, since 2004 or so, 2005 or 6. I've known him all that time. He went to undergraduate at Princeton, then spent time at Columbia for medical school, went to UCSF for internal medicine and residency training, and then finally went to Harvard System, BI Deaconess, for his cardiology training and vascular training as well. He also did his MPH at that time there. I actually met him a year after that, or at the end of his fellowship, when I was at Cornell. I think he was coming right out and looking for jobs, and we couldn't snatch him, but he went up to Columbia, and I've watched him do some amazing things. And the time that I've known him over the past 20 years or so, he's risen to full professor of medicine at Columbia Medical Center. He has over 200 publications and really publishes a lot on outcomes in cardiovascular care, and really leads into him being an authority in the field of interventional cardiology and where we're going. The lecture today is a good example of that. There's been a lot of debate about stable ischemic heart disease from the guidelines over the years, including the more recent revascularization guidelines. And so his topic today will give an opinion based on the data on stable ischemic heart disease from the interventional cardiology perspective. You can see the title here is Rationale for Revascularization of Complex, Higher Risk and Indicated Patients, the CHIP premise. So without further ado, Dr. Kirtane, the floor is yours.
Well, thanks so much first for that kind introduction. And Hari's been a friend for a long time, so it's really great to be invited by you specifically. And then also to Hema, and thanks for those words about the named lectureship. It's always an honor to be nominated for these types of things. I sometimes feel like I don't deserve them. I was speaking to Jeff Moses, one of my mentors here at Columbia, and he told me he gave this lecture 20 years ago. So I told him I had big shoes to fill. It's even more challenging when you have folks in the audience who literally you haven't met since your wife's college days and my parents and that sort of thing. But I think the idea behind this talk is to make it accessible. I've always liked grand rounds that were clinically based, also data-based, but then bringing it ultimately back to our individual patients, even our families. And so I'll have examples in the talk that hopefully we can all relate to. I do want to share with you the objectives and the goals of the talk are really to talk about what our goals are for patients with stable ischemic heart disease, talk about what the potential rationale would be for revascularization in those patients, and then really emphasize that we in clinical medicine offer therapies based upon patient risk. So it's all about the risk of the patient, how we can potentially help that patient and their family, and that's how we decide what to do. And so that'll be the theme for the talk, and I'll talk you through symptoms, prognosis, and how we deal or think about revascularization for chronic stable syndromes. Here are the disclosures relevant to the talk, the planner, as well as myself. These are really just grants from a variety of sources for research that we do at Columbia and the Cardiovascular Research Foundation. Also would encourage folks to put questions in the chat. We'll try to answer them at the end and just save them up as time goes, and we'll certainly try to answer them. So I'll start off with a case. This was how I always grew up with grand rounds. It'd be always clinically based with a case. And this is a patient I still take care of, but who I saw several years ago who had hypertension, chronic kidney disease, ischemic cardiomyopathy. The EF was about 30%, known to have a chronic total occlusion of the right coronary artery back in 2006. She had been doing well and then had worsening dyspnea on exertion, escalated medical therapies that were appropriate, and was referred to our institution, but not to me as an interventionalist, but to our heart failure team. And the idea was is she wasn't doing well on meds, so could she be considered for a stem cell trial or advanced heart failure therapies like LVAD or transplant? And I got a call from my heart failure colleague who said, before we do all that, I think she needs a cath. And the idea here of this talk is to essentially focus back on the fact that coronary artery disease, especially severe and complex coronary artery disease that is symptomatic, is something that we can help. And potentially by helping, we can change prognosis and also change the symptoms in terms of the patient's experience. And so the reason why it's important to state that is because there's a lot out there that talks about less is more. We do too many procedures. We're predatory on patients. And this is exemplified by this cartoon that was in Newsweek about 10 years ago, where by saying no to any procedure we would do or therapies, that can actually save your life. And look at on the right, that's all of us trying to make money or do what we want to do to take care of the patient in a way that's not actually taking care of the patient. And the byline of this is that by doing so, we can also save the healthcare budget. So if we eliminate unnecessary therapies, not only can you save your life, but you'll cost less in terms of doing it. Now, I view that as somewhat pejorative, but the reason I view it that way is because I do think that there are excesses in care. And I want to emphasize to start off with that there's a wide variety or variation in rates of therapies, such as percutaneous coronary interventions, which is what I do, based upon your region of interest. So if you look at certain areas for the same patient, same demographics, there's a lot more PCI being done in compared to other areas. And it's this variability that's somewhat concerning because it means that while there may be underutilization in some areas, there might be overutilization in other areas. And how do we regularize this? Similarly, if you superimpose costs to the system, and this is regional variation in spending, you basically see exactly the same thing. And in certain areas like Manhattan, where I practice, it's much, much more Medicare spending. And then other areas, there's a lot less, almost half. So in some respects, we do have to confront the fact that there is what I would like to call shamuloplasty, or doing a PCI in a patient that has minimal symptoms, doesn't really have any limitation with it. It's not in a dangerous location. That's not something that's necessarily indicated, and those types of procedures need to be curtailed. And so what actually happened about 10 years ago is there were multiple societies came together and came up with what was called the appropriate use criteria for coronary revascularization. The idea being that if you take a generic patient, we know they're not generic, but if you take a generic patient scenario and think about those patients. So somebody who's not really symptomatic, doesn't have a proximal coronary lesion, isn't really on medical therapy, it generally might make sense to treat those patients medically. On the other hand, somebody that has a severe proximal LAD with symptoms, it might make sense to revascularize those patients. So let's come up with a series of criteria and define what is likely appropriate and not so appropriate. And in doing so, actually, these were good efforts, and these efforts led to a reduction in inappropriately rated cases, those so-called some shamuloplasty, as I said, versus with also some cases that might be inappropriately rated but may have some clinical reasons, but those rates came down significantly, and the rates of appropriate procedures went up. And this was true not only at the patient level, but also at the hospital level. So I think we have addressed some of these types of things. And in general, when you look at rates of inappropriately rated procedures, once you start getting below the 10% threshold, it tends to be somewhat of a good thing. And this has been done in orthopedic surgery. It's been done in other specialties as well. The idea here is to take the right patient for the right reasons, revascularize patients that have significant ischemia, and then in doing so, you can optimize outcomes both for the patient as well as cost too. But the question is it still does get back to this, and we still live in this environment where there is this perception of overuse. And what I would like to say is it's time now to focus more on underuse, and the idea that perhaps in our desire to be so prescriptive about what we do, are there patients who are being missed who could really be helped by coronary revascularization procedures? And is that measurable? Are we able to demonstrate that? So it turns out that the initial uses of appropriate use criteria started in LA County back in the 90s. And the idea here was not to identify overuse. It was actually to determine in LA County if there were patients who met criteria for revascularization but weren't getting it. And what they found is that folks that did meet criteria, i.e. significant symptoms, significant anatomy, but didn't get revascularized, had a greater incidence of mortality than those that actually did get revascularized. Of course, this is an observational study, and we know that there may be reasons that they're not getting revascularized that have to do with comorbidities and beyond. But the idea here is that appropriate use can also be used to look at underuse, not just overuse of procedures. And I'd start by saying there is such a thing as inappropriate medical therapy. So where patients are not being offered coronary revascularization when really, in fact, they should. Here's an example of this. I can say it, it's great for me to say, but how do I substantiate it? Well, there's some data. And this is from 2014, Action Get With the Guidelines Registry, that looked at various hospitals and their rates of medical management for patients who presented with a non-STEMI, so myocardial infarction, and diagnosed left main or three vessel disease. If you think of that scenario, that's sort of two scenarios or two class 1 indications for revascularization. And yet there are hospitals that are treating these patients medically 25%, 30%, 40% of the time. That's way too high. Even if we assume that there may be patients in this mix that don't want revascularization, maybe too elderly, they have other comorbidities, is it really that high that we're withholding potentially life-saving therapies for these types of patients? I think that that's a problem. Similarly, we had one of our fellows who's now at the MGH do an analysis where he looked at patients who presented to the hospital with new incident heart failure. As you all know, in the Northern Hemisphere, ischemic cardiomyopathy is probably the most common or is the most common cause of heart failure. And so for patients who present with new heart failure, every intern and resident knows on the cardiology service that you need to think about ischemic heart disease. So we asked not how frequently they got revascularized, how frequently they were tested to see if they had coronary disease. And it turns out within 90 days, less than 30% of patients even had a stress test or some way to determine if they had coronary disease as their etiology. Now, some people have come to me and said, well, we don't believe these data. You're clearly underreported this. It can't be right. So I say double it, make it 60%. It's still too low. For patients with heart failure coming into the hospital, we ought to be thinking to test them to determine if they have coronary artery disease. And it turns out that a more recent publication just a few months ago in JACC showed the exact same thing with 35% of patients undergoing CAD testing who present with new heart failure. Now, the reason this is important, by the way, is not just to triage patients to coronary revascularization. It actually has been shown that if you have a diagnosis of coronary disease, the incidence or sort of the treatment of these patients with guideline-directed medical therapies for heart failure is also higher just by getting an angiogram or diagnosing heart failure. Now, again, you can say this is confounded data, that people that got diagnosed clearly were better candidates than the ones who didn't get diagnosed. But the point is that we need to be thinking about why the patient has heart failure. And if we operate under the assumption that we're doing too many procedures all the time, we're going to miss significant disease in these types of patients who could have a prognostic change based upon our clinical management. And I'll show you that later at the end. So when we talk about goals of therapy, I think it's important to refocus who we're trying to take care of. We're trying to take care of patients that have significant symptoms because we could reduce their symptoms, or patients that have a significantly altered prognosis on the basis of their coronary disease. And so I'll take you through data addressing both symptoms and quality of life, as well as prognosis, and where the data stands for those patients who undergo coronary revascularization procedures. So first, starting off with symptoms, there have been abundant studies looking at reductions in angina from coronary revascularization, whether that's PCI or surgery. And all of the studies show that if you take patients with significant angina, you can lower their anginal burden by revascularizing them. But importantly, it's not just reducing their anginal burden, it's doing so without the use of medications or using less medications. Now, I'm not talking about medicines that alter the prognosis. We're going to talk about that a little bit later, but I'm not saying use less aspirin, use less statins, use less diabetic medications. I'm talking specifically about anti-anginal medicines, medicines that are used to treat symptoms. All of the studies that have randomized patients to revascularization versus medical therapy show that not only is there a reduction in angina, but it's possible to do it on less use of anti-anginal medications. Now, more recently, the Orbita trial was published, and there was a lot of press that came out at this time because this was a sham-controlled trial of PCI versus a sham PCI. And what I think got lost in all of the hoopla of this, and a lot of this was because of the editorial that came out, are a few things. One is an important learning point, and that learning point is that if you take patients who are well controlled with symptoms and treat them medically, the incremental benefit of doing a procedure on that patient versus a placebo procedure is less than many people were telling their patients. So the exercise time was greater in the PCI arm compared to placebo, but not by that much more. It was about 20 seconds more. Now, the fact that people have focused on the fact that there was no statistically significant difference in the two arms is something I've argued is somewhat irrelevant, because if you doubled the size of the study, it would have been statistically significant in favor of the actual PCI compared to sham. But the point here is that for many patients, they can be controlled with medications, and I think that was an important teaching point from Orbita specifically. Unfortunately, in the backlash after the editorial, or sort of the noise of the editorial, we started seeing articles like this. Unbelievable, heart stents fail to ease chest pain. Heart stents don't actually help treat chest pain for this poor guy who's like clutching his chest, actually having maybe an MI. Thousands of heart patients get stents that may do more harm than good, and ultimately, is this all just a placebo effect of the heart? And a lot has been made of the fact that Orbita was a sham-controlled or placebo-controlled trial. And I do commend the investigators for not only doing that study, but they have a follow-on study, Orbita 2, going on right now. But it's interesting to note that despite the fact that there was a sham control, if you look at endpoints that have more traditionally been used in clinical trials, like freedom from angina, it was reduced with the actual PCI procedure compared to the sham procedure. Moreover, that was occurring despite the fact that most patients only had angina about once a month. So really rare symptoms, and yet you still could show that more patients were angina-free at the end of the day. And the really important learning point, at least for me, is that many people have said this study was so unique that it had a placebo and this unmasked the true effect of the therapy. Yes, it is unique that it had a placebo, but if you compare it to two other non-placebo controlled trials, the reduction in terms of angina is virtually identical. So these results are consistent, they're robust, and there is nothing, in my opinion, magical about the placebo in Orbita that then unveiled a true treatment effect. This was just clinical medicine shown to actually be taking place. Now, in terms of the key characteristics of the population that are important to emphasize, many people have criticized the trial by enrolling patients that had physiologically negative lesions. In other words, they did physiology, there was not really a drop in pressure, and so why are they treating these patients? The reason is because in real clinical practice, a lot of people treat these patients, or certainly were treating these patients. We've actually seen people who treat these patients because of the angiogram and tell the patient they've saved their life for stable ischemic heart disease. All of those things are not appropriate. And as I mentioned to you before, this idea that we magically can save people's lives in stable ischemic heart disease, single vessel disease, by revascularization is actually that. It's magic. It's not actually true. So this is good that they did this study and looked at the physiology and showed the angiograms in the Lancet supplement, because it tells you that we ought to be a little bit more circumspect in what we tell our patients. But it is important also to remember that these patients had symptoms that were well controlled, had approximately monthly angina on 3 meds or more, were being followed very, very closely by a truly dedicated lead investigator, and had access to that person's cell phone and beyond. And after the trial was over, many of them actually crossed over and had PCI. They also had good exercise tolerance by VO2 max and minimal ischemia by stress testing. So the idea here is that you don't have to treat everybody with revascularization, especially if they have single vessel disease, branch vessel disease, and are well controlled with meds. Now, what's interesting is the way our guidelines typically look at this. And they take studies, not just like Orbita, but they take studies in the past and really say that if you have stable ischemic heart disease, at least in the US, you really should try a sublingual nitro, a beta blocker, maybe calcium channel blocker, potentially ranolazine. And only if those things are unsuccessful should you consider revascularization to improve your symptoms. Now, if you present that to me as a patient and I have severe symptoms, like many of us, think about how much you want to take medications. And by the way, every single one of these medicines I've listed does not alter the prognosis of the patient and the disease. Not one of them changes prognosis. Do you really want to try 4 antiangials if you have significant symptoms before you get revascularization? I think many of us would actually say if the revascularization has a good chance of alleviating my symptoms, reducing my medication burden, that's a rational way to go. And that's a conversation we need to have with our patients, as long as the risk of the revascularization can be mitigated. And this point that's rarely discussed is that while the guidelines espouse treating patients with antiangials, none of these meds change prognosis. Not even beta blockers in stable ischemic heart disease with normal ejection fraction. They all have side effects, and polypharmacy is a real issue for our patients. So the question is if we take the right patients, significant disease, significant symptoms, and revascularize them, why don't we offer that? Interestingly, the Orbita investigators published a follow-on study in JACC, where it was unblinded, and they took people in the cath lab, again, with single vessel disease. And what they did is they exercised them on a bike. They then dilated and stented the coronary artery, and then they re-exercised them. Now, remember, this time the patients, unlike in Orbita, knew that their stenosis had been relieved. They actually exercised for a minute more. And in fact, when they stopped, all of them stopped, or virtually all of them stopped due to chest pain before the stenosis was open. After it was open, none of them had chest pain, and they all stopped due to physical exhaustion associated with an increase in lactate. So the bottom line here is that if you have a physiologically significant stenosis in a patient with symptoms, by relieving that obstruction, you can improve their symptoms pretty dramatically. And similarly, even other randomized trials that have looked at strategies, such as the COURAGE trial, we'll talk a little bit more about it later. This is a trial that randomized patients that had significant coronary disease to revascularization with PCI versus medical therapy alone. As a strategy for patients that had no or minimal angina, most of the medically treated patients could remain on medical therapy and didn't have to have a PCI. Why? Because their symptoms were minimal. It was going to be hard to make them feel a lot better. But those that had more significant symptoms, daily or weekly angina, they had rates of crossover that almost approached 50%. Because those people had more symptoms, the medicines weren't enough and they needed to cross over. And so this is back to just clinical medicine 101. If you're confronted with a patient in the office, ask them how severe their symptoms are. Take a good history, figure it out, and then if their symptoms aren't that severe and they're willing to take medications, try them. If their symptoms are more severe, then why subject them to escalating medical therapy as long as you know you can revascularize them safely and effectively? Now, the same thing was basically validated in the ischemia trial. This is a large clinical trial that was published a few years ago that showed that patients who were randomly assigned to cath versus no cath, basically studied those patients and tried to look at both symptoms as well as prognosis. They did detailed quality of life assessments both at baseline and also at follow-up, and they used something called the Seattle Angina Questionnaire, which is a validated instrument to assess symptom status, and they had high rates of follow-up. Just to put a point of reference, the Seattle Angina Questionnaire uses an anginal frequency scale, where 100 means you have no angina whatsoever, 80 means you're having it sort of once a month, and then 60 and beyond once a week and even more frequent. And so in general, in this trial, which randomly assigned people to cath versus no cath, they needed to take patients that didn't have a lot of symptoms. Why? Well, the reason is that if you had a lot of symptoms and you were randomized to the no cath arm, you were going to cross over and have a cath. So in general, they had to take patients that had angina that was occurring once a month or fewer. And that was to allow there to be less crossover in the trial. Despite the fact that they took patients that had less angina, what they were able to show in the trial is overall, there was a reduction in angina seen with the invasive strategy, taking people to the cath lab. And by the way, in that trial, 20% of patients who were taken to the cath lab had no revascularization done. Despite that, there was a reduction in angina seen with the invasive strategy. Now, if you take people, though, that had more severe angina, daily to weekly angina, that's where the benefits became even more striking in favor of the invasive arm. If you took patients that were asymptomatic, there were really no differences between the study arms because you couldn't really make those patients a lot better. And I think this was also, by the way, substantiated with less anti-anginal therapy, so proving what the prior studies had shown, less meds needed to reduce their angina more effectively. And this was, I think, the most important slide that was presented by John Spertus at the AHA. And what it does is it stratifies the ability to render a patient angina-free based upon how much angina they're having at baseline. So I'll just take you through it really quickly. On the right of the slide, these are patients that have no or minimal symptoms. If you follow those patients, there's really no difference between the invasive arm and the conservative arm because they have no symptoms. You can do all you want to them, but they're still going to have no symptoms. So that's why there's very little difference. However, as you get to more severe angina, this is where you really see the differences between the treatment arms. And the probability of rendering a single patient angina-free is much higher. And in fact, you only need to treat 3 patients to render 1 additional patient angina-free with a number needed to treat of 3 if their angina is weakly. And unlike the COURAGE trial, which predominantly used bare metal stents and or balloon angioplasty, in this trial with drug-eluting stents, these results were durable out to 3 years. Again, the idea being if you have a patient, for instance, executive physical, they have some diaphragmatic attenuation, they have no symptoms at baseline, you can revascularize them all you want, but they're not going to feel a lot better. On the other hand, if you have somebody with significant symptoms and you revascularize them or even just cath them and then lead to revascularization, you're going to help those patients. We have to be good doctors, though, and there's some pretty interesting data out there. This is also from the Mid-America Heart Group from Suzanne Arnold that show that actually as doctors, we do a pretty not so good job at recognizing if our patients are actually having angina. So this is individual physicians in the offices out there, and they asked the doctor, how frequently is your patient having angina? And what they then did is they gave the Seattle Angina Questionnaire to the patient and had them report, are you having angina or not? And it turns out that there were some doctors who underreported their patients' angina 60, 70, 80% of the time, and other doctors who were totally concordant. So what's the difference between these two doctors? Is it maybe these ones over here didn't have to be seeing, 80 patients a day with RVUs and that kind of thing, and they actually could take the time? Is it perhaps that they went beyond just asking if you had chest pain and sort of said, the patient says to you, I have this happen all the time to me. Do you have any chest pain? No. Well, what do? I kind of sit on the couch all day. Really? Tell me a little bit more about that. Well, I used to be able to walk to the end of my driveway with my dog, but I started getting more fatigued. And so now my wife walks my dog. So if you go into a little bit more detail in the office, and by the way, I'm an interventionalist, but I see patients in general cardiology clinic as well. And it's one of the things I enjoy doing a lot. Those types of conversations are really important. You need to ask people when they say they walk, are they walking slow? Or are they walking fast? If they tell you they run, well, how fast do they run? Go into that level of detail. One of the advantages of being a specialist is that you don't have to talk about everything under the sun with the patient, like healthcare maintenance and things like that. Those things are important. I'm not minimizing them. But as a specialist, you can really, really hone in and take the time to take a good history, because you'll then be able to appreciate and not under-recognize your patient's angina in this proportion of time, like these physicians over here. Now, similarly, in addition to the how much angina they have, it turns out that the more severe your disease is, the more likely you are to reduce a patient's angina through revascularization. This is data from the FREEDOM trial, multivessel disease, either CABG or PCI, pretty dramatic improvements in Seattle angina frequency seen with either revascularization strategy. The exact same thing has been shown with EXCEL. This is the left main disease. So if you have prognostically important like left main, you can really reduce patients' angina this way. And the same thing has also been shown in the STITCH trial with ischemic cardiomyopathy. And finally, for this study was the data that we presented at TCT last year, looking at patients that had no option. They were turned down for surgery, and yet they underwent PCI. And it turns out, once again, we could dramatically improve their quality of life and their anginal frequency by taking care of these patients. And it's important that these patients were turned down by surgeons, but yet referred for PCI. So it wasn't just turned down for surgery, go home, medical therapy alone. We felt that those patients needed revascularization to help them. It was just too high risk to do with surgery, so then PCI was offered as an alternative. So this is just another example, a case example of this, the patient I had to treat, and I still follow. He had a low ejection fraction, multiple risk factors, came to see me for a second opinion, had persistent angina, had been medically managed, had interventions in the past, but was told nothing further could be done for him. And he had ischemia on his stress test and was on 3 or 4 anti-angels at the time I saw him. He actually had prior CABG, so he'd already been surgically revascularized, had this REMA to the RCA, which had been treated before but had restenosed. It had a stent that kept narrowing, and was told there was nothing that could be done, largely because his right coronary artery looked like this. It was just really just this conus branch, and you couldn't see the rest of the right coronary artery. Because we have specific expertise in opening chronic total occlusions, we brought him in. This is dual injections, so injecting through the native right as well as the REMA. We knew that the REMA was not going to stay open because it kept restenosing, so the idea was to open his chronic total occlusion. And guided by this REMA shot, using techniques like anchoring balloons, we were able to actually enter back beyond the stent by going subintimally. This is sort of the wire in the distal vessel, and here's the complete revascularization of the right coronary artery. I still follow this patient like 5 years later. He's doing great. And once again, we down titrated or took him off the anti-anginal therapy he was on because he didn't need it anymore because he didn't have angina. So how our patients with real symptoms feel after coronary revascularization? It's much nicer in the days of emails and tweets and LinkedIn and all that other stuff to get letters. And this is a letter from a patient. I thank you for all of your help. It's a great feeling to be angina-free. You're a grateful patient. But the question is, do we need to revascularize everybody? And remember, he was on less medication. And I hope you can understand from the way I presented this that the answer is no, we don't need to revascularize everybody. We really need to revascularize those that have real symptoms. So The guidelines support this. It's class 1A in the current iteration of the guidelines to improve symptoms in stable ischemic heart disease for those patients that have angina despite medical therapy. But in terms of revascularizing everybody, this is another note I received from another patient who thanked me so much for taking the time to meet with him and his family. He was referred for chronic total occlusion intervention, but had no symptoms at all. And so I went through with him why, despite the fact that he had a blockage, which intuitively he felt needed to be fixed, he was feeling great. It was in a territory that wasn't that ischemic or that significant. We opted to do medical therapy. He was reassured, and he sent me a similar note. So it can be very satisfying to take care of these patients if you actually take care of them in the way that you would want yourself or your family members to be taken care of. If you have symptoms, then think about the most potent way to do it. If you don't have symptoms, then obviously other ways to do it are going to be equally effective. So moving on to prognosis, that's the second half of this talk. I want to talk just for a second about the fact that we always fixate on this as being measured by hard endpoints. And yet, so we sort of poo-poo the soft endpoints of symptoms and quality of life. I think it's a little bit pejorative to think about it that way, because for many patients, how they feel is probably more important than are you going to extend their life by a small amount. But I also think it's important to say that in stable ischemic heart disease, we can improve prognosis by coronary revascularization if we focus our therapies on the highest risk patients. Because most people coming through med school right now are taught that in stable ischemic heart disease, there's no prognostic benefit to anything we do other than medical therapy alone. Now, medical therapy is super important. As I stated to you before, I see patients in the office. And for me, some of my best success stories are not what I've done in the cath lab. It's when I go into the office and I can convince somebody, for instance, a patient I know I can think of the top of my head who was quite obese, diabetic, hyperlipidemic, and I convinced him to have gastric bypass surgery. And what happened after that is his lipids were normalized. He came off his insulin. He was doing great. And that's really, really important. So irrespective of whether we do an intervention or not, one of the beauties of being a cardiologist first and an interventionalist second is that I can take care of patients in the cath lab, but I can also take care of them out of the cath lab. And that's often far more important than what I do in the lab. So things like dietary loss, smoking cessation, aspirin, statins, disease modifying agents, super important. As interventionalists, I may forget, what the latest antipsychotic is because I did internal medicine residency a long time ago. I can't forget the way to treat diabetes because that's really, really relevant to the care of my patients. We do a terrible job with this. If you look at this is patients with self-reported CAD, the rates of risk factor modification control, things like blood pressure, physical activity, BMI, lipids, it's awful. Just think of one of yourselves today. You're going to be at work today. It's a busy day. You're taking some time out. Do you have a plan to work out at some point today? Because it's important to do it, right? We recommend to all of our patients, 3 to 4 times a week, 35 to 45 minutes. But do we have a plan for ourselves? And if we can't do it for ourselves, then how can we tell our patients or expect our patients to do the same? We know from studies like Courage that if we get these things at goal, not smoking, getting the BMI down, A1C down, there is a mortality benefit to doing that. And so the more things that are at goal, the better these patients do, and the worse, lesser that are at goal, the worse they do. So really important to take the time to spend with these patients. A study that I love to talk about is a study that, again, the Orbit investigators did on the tube in London, on their version of the subway. They basically took patients and asked them, how many years of life would you need to add to be able to take a statin every day? Because remember, when you take statins, you're taking the same medicine every single day, and you're not perceiving a benefit to it, right? Your numbers may come down, but you don't necessarily feel better for a while. So how many years of life would it take for me to add to make it worth your while to take a statin every day? And over here on the left of the slide, there are people who sort of just believed, or maybe they were already on statins, and they said, you don't really have to add very much, I'll take it. There's a wide smattering in between. Some people say 2 years, 3 years, 4 years. And then there are patients here who say, you got to add more than 10 years to my life to make me take the statin every day. Well, I have news for you. If you're a sensible person, you know these people are not going to take a statin. They may have said 10 years because that was the upper limit of what they can do, but they are not taking it. So the idea here is we really have to talk to our patients about each and every medicine we prescribe and explain to them why it's important to take. There's good data out there that shows if we write a prescription, what proportion of patients will start taking that prescription as we've written it. We'll even fill it. So just think to yourself, the reality is it's about 2 and 3. And then of the 2 and 3 that fill the prescription, what proportion actually take it as prescribed, it's again 2 and 3. So if you multiply those probabilities together, you're already at like 50%. So we may think we're great, we're the doctor, we write a prescription, the patient's going to take it. The reality is we have to take the time and effort to make sure they're actually taking it. And so I call pharmacies, I talk to family members, are they really taking the medicines? And you'd be amazed at the variety of what you start finding. And you have to have this relationship with patients so they tell you the truth and not be intimidated that they don't want to disappoint you, the physician. And so I'll confess to them, look, I know when I take antibiotics for something that I had, do I really finish the whole dose? And then they sort of see that you're doing that, and then they may confess to you. So the idea here is to make it a relationship and spend the time. Interestingly, when this group, the study group, looked at the disutility of taking the statin compared with the utility for the actual patient based upon their actual risk, turns out in 25% of patients, the disutility they expressed exceeded the benefit they were actually going to get from taking the statin. So this is why it's so important to go through this in detail. So beyond medicines, though, and I really want to emphasize how important medicines are for prognosis, and it's a whole range of disease-modifying medications. Can revascularization change prognosis as well? And the answer is, if you look at the COURAGE trial, people will say, no, there's no difference in death or myocardial infarction from PCI versus medical therapy in this trial. But the reality is can we find groups of patients for whom it might make a difference? So for that executive that is asymptomatic and has a positive stress test and has some diaphragmatic attenuation, we're not going to change that person's prognosis by revascularizing their coronary. But are there groups of patients that have, for instance, severe multivessel disease, and we revascularize those patients that we could change their prognosis? And so the whole idea when we look at evidence-based medicine is not to take the average treatment effect from a clinical trial like COURAGE, this slide I just showed you, but to risk stratify patients and to appropriately treat the ones that are going to have the best outcome from revascularization, for instance, and not treat the ones that are not going to have much of a difference in terms of their outcome. So who are those patients and how can we find out? Well, first, I'll start by saying that diagnosing and treating severe coronary artery disease is prognostically important. At the minimum, just putting the patient on a high-dose statin, you're going to change their prognosis. But beyond that, there are certain disease types for which coronary revascularization itself can improve prognosis independent of the medicines we provide. So here's an example of a slide from an older guidelines deck that's really important, and it shows how important coronary anatomy is to prognosis. If you have single vessel disease, 5-year survival rate's pretty good. But if you have 3-vessel disease involving a severe stenosis of the proximal LAD, 67% survival at 5 years. So if I have a 60-year-old woman in my office and she comes in and I need to make the diagnosis of coronary artery disease in her, she has a widely different prognosis based upon what anatomy she has when she's sitting in front of me. And in fact, if it's assuming medical treatment only, this is an asterisk from the actual guideline slide itself, if she's looking at me and she's sitting there with multivessel disease involving the proximal LAD, she has a 4 in 10 chance of not being alive at the age of 65. That's really prognostically important, and that's something that I need to try to diagnose so that we can potentially influence whether she's going to be around in 5 years. Now, observational data shows you, and this is the data we published last year, but from the Alberta group, that if you truly have severe 3-vessel disease with greater than 70% stenosis in all your vessels or a tight left main, your prognosis is improved with coronary revascularization compared to medical therapy alone. This analysis is confounded, of course, because the ones who get revascularized are probably better candidates than the ones who don't. But nonetheless, there are signals showing that revascularization can improve prognosis. This is one of the reasons why in the European guidelines that existed before, they basically said if you have a high pre-test probability of disease, in other words, you have severe symptoms and you have risk factors, it's class 1 to go to the cath lab and diagnose what's going on, class 3 to do any type of stress testing or anything else like that. And the reason for that is that the teaching has always been if your pretest probability is that high, if you do a stress test and it happens to be negative, the post-test probability is high enough that you don't just believe the negative stress test. Contrast that approach with, at the same time, what the US guidelines said. And that was that you basically only made it to the cath lab if you had a very high risk stress test of any etiology or any modality that was done. So why is there this discordance between what we do here in the United States and what people do outside the United States? Does it have something to do with the healthcare systems we practice in? And the answer to that is yes. So in Ontario, which is similar to Europe in the sense that it's a centralized healthcare system and the the threshold to go to the cath lab is a lot higher. In other words, they're not cathing that guy with the executive with the positive stress test. The rate of left main or three vessel disease, prognostically important disease, is almost double in Ontario as it is in New York State. Why the discrepancy? Because we cath too many people. We take too many people that have, breast attenuation on the nuclear, bring them to the cath lab, and they didn't need to be there. They were going to be fine. So the idea here is that the anatomy is important, and that's why the guidelines were so different. The European guidelines, they're used to seeing people with disease, so they say go to the cath lab. In our guidelines, it says do everything you can to avoid getting to the cath lab because you're probably going to end up with that shamiloplasty that I talked about before. So let's say you do find significant disease. Is there a benefit? Well, left main disease, clear survival benefit with surgical revascularization versus medical therapy alone. Some people say these data are too old and it's only 150 patients. Well, the reality is if you can show a halving of mortality in 150 patients, you probably shouldn't randomize another 150 because what about those people who didn't get revascularized? Similarly, for multivessel disease, meta-analyses of studies show that you can reduce mortality and certainly cardiovascular adverse events such as CV death by surgical revascularization compared to medical therapy alone. But many people have argued that these data are old and they existed before statins and we can do a lot better now. I think that's a reasonable argument, but I don't think it takes away the fact that if you have significant disease, you potentially could improve prognosis for these patients. And the way we improve prognosis is also interesting. And I don't think this is very well known that you can reduce spontaneous myocardial infarction, meaning MIs that occur outside the cath lab, by revascularization, even with PCI compared to medical therapy alone. Now, sure, you cause events in the cath lab as well, and the two will therefore offset. But the fact that MI is reduced outside the cath lab is something that is not taught or understood very well. This was also shown in the FAME2 trial published in the New England Journal a few years ago, showing a reduction in myocardial infarction in 5 years with PCI compared to medical therapy alone. Now, if you don't believe me, let's go to the biggest study of them all, the most recent study of them all, the Ischemia trial. So this study took patients, and it was originally supposed to be 8,800 patients with a primary endpoint of CV death or myocardial infarction. The idea or the hypothesis being that if you took patients that had stable ischemic heart disease and took them to the cath lab, you could reduce cardiovascular death or myocardial infarction compared to just treating them with medical therapy alone. That was the original hypothesis of the trial. Now, unfortunately, the study could not enroll fast enough, and so it ultimately randomized 5,179 patients, and the primary endpoint was expanded beyond cardiovascular death and MI to a 5-point composite. Patients were randomized to cath versus no cath, so this is not a trial of revasc versus no revasc. It's a trial of cath versus no cath, and patients had a median follow-up to 3.3 years. So not that 60-year-old, she's not being followed to the age of 70 or 80. She's being followed till she's about 63, 64 years old. Really important when we try to apply these data to our patients. They also did a blinded CTA upfront before the randomization. And the reason for that is they thought it was unethical to randomize patients with severe left main disease. And what they actually found is about 8% of patients in the trial that had sort of ischemia on stress testing had a significant left main that would have precluded randomization. That's really important when you're applying these data to your patients, because it means if that woman's sitting in front of you in clinic and you haven't ruled out left main disease, especially if she has a positive stress test, she's got a pretty high likelihood of it, almost 10%. And so don't just indiscriminately apply the results of this trial without looking at some anatomic localization of disease. Patients by and large had a normal ejection fraction. As I stated before, the majority were asymptomatic to mildly symptomatic. And of the stress testing modalities done in the trial, about a quarter of patients had routine treadmills, not even echo, not even nuclear or anything else like that. And that was partly because they had to expand the trial more outside the US, and some of these centers didn't actually have the ability to do imaging-based stress testing. Within the trial itself, as I stated to you before, 20% of patients in the invasive arm got no revascularization at all. Now, some of those may have had very, very severe disease. Other patients didn't have disease severe enough to merit revascularization, because to get into the trial, you needed to have a CTA that showed a 50% stenosis or greater. So if you have a 60% lesion, no need to revascularize it, it was left alone. And similarly, over the follow-up period, about 30% total, 25 to 30%, ultimately crossed a cath. So it was low, but not so low as to be discounted entirely. For those that actually did get revascularized, about 3/4 of them had PCI and another quarter had CABG. So it's not a PCI trial. It's largely PCI, but it does include some CABG as well. And as I stated before, it also includes some medical therapy, 20% of the overall invasive arm. Now, here's the primary endpoint of the trial. And what it showed is over the entire follow-up period, there was no difference in the two study groups. But it also showed a very important finding that I think has been glossed over. And that is that up front, there was a risk of the invasive arm. Why? Because we're doing PCI and CABG on these patients. But at almost 2 years, those risks were negated because there was a continued accrual of events in the conservative arm. And at 4 years, there was actually a lower rate of events in the invasive arm compared to conservative arm with a p-value that likely was around 0.05. So the trial overall was negative. But if you remember, the original design of the trial was looking at cardiovascular death or myocardial infarction. And while the study was not powered to look at it, the curves look identical to the other endpoint with an increased hazard in the invasive arm, wash at 2 years, and then at 4 years, actually, a statistical significantly reduced rate of cardiovascular death or myocardial infarction with invasive arm compared to conservative therapy. I'm going to repeat that because I don't think people know this about the trial, that at 4 years, there was a statistically significant reduction in cardiovascular death or MI with the invasive arm compared to the conservative one. That is not something that is widely promulgated, but yet is important because that was the original hypothesis of the study. Could revascularization or could going to the cath lab reduce your rate of events? And here you see that at 4 years, there was this reduction. Now, how did this happen? Was it death? Was it MI? Well, it turns out it was largely relating to MI. And just like I showed you before, in the meta-analysis of studies, there was a reduction in spontaneous MI in the invasive arm compared to the conservative arm. This was offset up front by an increased procedural risk, but again, at that 4-year time point, there was ultimately what looked like a lower rate of MI, specifically spontaneous type 1 MI, the types of MIs that many of us went into cardiology to prevent. We don't want patients to have type 1 MIs, and it was reduced by taking a patient to the cath lab at the initial time of randomization. Now, interestingly, then this is data in circulation from Bernard Treitman and colleagues. There is a reduction irrespective of whether you get PCI, CABG, or are managed medically in the invasive arm of the trial relative to the conservative arm. So you'd ask, well, why is the medical therapy arm reduced? Well, the reason is because they didn't have disease. So the ones that didn't get revascularized didn't have disease, mostly. The ones that got revascularized had lower rates of events. And in fact, this group here should be even higher if you think about the types of patients that had disease that might have merited revascularization. So we are preventing MIs by taking patients to the cath lab up front. And it may seem crazy that I'm saying this, but I'm literally just reading you the data that's been published and presented to date. In the New England Journal of Medicine supplement, there's actually a nice Bayesian analysis talking about the risks and benefits of what happens. And you can see that at 1 year, the invasive arm looks worse. Why? And this is with respect to cardiovascular death or MI. The reason is because there's an upfront risk of the procedures we do. But at 3 years, and then most certainly at 5 years, the probability curves all favor the invasive arm versus the conservative arm with respect to the endpoint of cardiovascular death or myocardial infarction. So does this mean we have to revascularize everybody? Again, the answer is no. And the reason I say that is we have time because the rates of cardiovascular death are not that different between the two study arms. In fact, they're not detectably different out to 2, 3 years and maybe even beyond. So the idea here is you don't have to act immediately. You don't have to cath the patient immediately. You can have a conversation, but I would say you need to diagnose the disease that you're dealing with before just saying, treat the patient medically, they're going to be fine. Not just because you need to diagnose left main, but you also need to know what else their anatomy is. If you're going to revascularize patients, it's important to revascularize them completely. And this is an analysis Greg Stone and colleagues presented more recently that showed that there's a reduction or a greater reduction with the invasive arm compared to the conservative arm if anatomic revascularization is achieved. And unfortunately, it was achieved in less than 50% of patients within the trial. Other caveats of the trial, remember, it was not fully powered for death or MI or cardiovascular death or MI. For patients with ACS, they were excluded. Patients with left main disease were excluded. And remember, you had to have a 50% stenosis on CTA to qualify. But for many patients, it didn't have to be 70 or 80 or beyond. Patients with reduced ejection fraction were not largely represented in the trial. And as I stated, those that had more severe symptoms or symptoms refractory to medical therapy, that was not the patient population being studied because they wanted to keep the crossover rates low. So average angina was monthly. If we look at other patient populations that have been studied, like those with ischemic cardiomyopathy, this is data from Stitch, clear reduction in mortality shown with surgical revascularization compared to medical therapy. And in ischemia, this was an important sub-study. Those folks that had heart failure or LV dysfunction at baseline, the conservative arm did substantially worse than the invasive arm of the trial in those patients who went to the cath lab. So if your ejection fraction is not normal, don't apply the ischemia results to your patient population unless you apply this result and therefore cath the patient. I would state that there's been a lot of controversy about the clinical practice guidelines that have come out, and that largely is fixated on survival. But if you look at the guidelines, one area that's been glossed over is this 2A recommendation of revascularization to reduce cardiovascular events in stable ischemic heart disease. And I'll just read it to state that revascularization is reasonable to lower the risk of cardiovascular events such as spontaneous MI, unplanned urgent revascularizations, or cardiac death. That's a pretty powerful statement and really makes the point that this is not just about symptoms. This is about, in high-risk patients, the rationale for revascularization to improve prognosis. In the last couple of minutes left, I'll just focus on what we've been talking about more as this CHIP premise. And the idea here is let's not focus on those executives with positive stress tests and minimal symptoms. Let's focus on patients that have true coronary disease, high risk features, lots of symptoms, and those are the people who we should really focus on in terms of revascularization. This is a paper we wrote about 5 years ago, sort of putting the stake out there to say these are the folks we need to treat. The idea here is to take care of patients who merit revascularization, i.e. they have an indication for revascularization. Not that every patient's indicated. In fact, the opposite of that. Let's focus on those that actually have an indication. The fundamentals here are that we shouldn't just only do the cases that are easy. We should sometimes focus on cases that are harder because those patients may have more to gain. And if I'm not adequately trained or I don't know how to do the case properly, then I need to find somebody who could so as to help those patients. That's hard in the United States because if we actually look at the rates of PCI and the rates of what people do here in the US, the annual operator does less than 1 PCI a week. So this is not for everybody. We need to be trained to be able to do this effectively. Similarly, even in the CHIP population, I want to emphasize again, we really have to be better at medical therapy as well. We looked at our patients that were referred for tertiary quaternary revascularization and found that even in these patients, 65% of them had their LDL at goal at the time of the revascularization. So in the cath lab, I have to do a good job, but I have to do a good job on discharge as well. And it's one of the reasons why in our lab, we've made it standard to add a lipid profile to standard screening labs. We need to be trained. We need a lot of different skills to be able to do these cases safely and effectively. And we've talked quite a bit about that in this document and beyond with a lot of educational efforts we make. This is the slide mentioning annual PCI volumes in the USA and how nearly half of operators do less than 1 PCI a week. Unfortunately, while those patients are certainly capable of diagnosing and triaging those patients for therapies, it's probably not the safest thing for a patient to have a high-risk intervention at somebody doing less than 1 PCI a week. I'll sort of close with 2 other slides. The first is to make sure that we're circumspect about what we can do at our individual institution. This was a slide that looks kind of funny, but it was from a randomized clinical trial of surgical revascularization versus PCI. And patients had multivessel disease. Each bubble here is a site in the trial. And at this site, for instance, the rate of CABG, adverse events, was 40% or greater, and with PCI, it was only 10%. And over here, assuming the same anatomy, the rate of adverse events with PCI was greater than 50% and 0 with CABG. So if you're a patient, how do you know if you're at this site or this site? You simply don't. And that's why as an operator, you need to know what your surgical expertise is, what your own individual expertise is, and try to make decisions based upon what you can offer the patient. Otherwise, if we homogenize this and offer every patient the same thing, we're just going to get an average treatment effect, and that's not good for our patients who don't want average. The final slide I'll show you is the first slide of the guidelines that have come out most recently. And given all the events of the last few years, both politically and socially and with everything going on, COVID and beyond, it was important for the guidelines committee to make a strong statement about improving equity of care and revascularization. But when we talk about equity, it's not just based upon demographics and socioeconomic status. It's also what hospital the patient shows up to, what doctors is the patient seeing. And I think it's really important to emphasize that irrespective of any other features, patients should be offered the therapies that can help them the most with an informed discussion to minimize the risks of those therapies as well. And so when we talk about the executive that had a positive stress test, somebody should tell that patient that you didn't need the stress test, you don't need to go to the cath lab. But on the other hand, if you have that 50-year-old or 60-year-old woman with bad, serious multivessel disease, somebody ought to make that diagnosis and then talk to that patient and her family about the risks and benefits of revascularization so you can take care of that patient most effectively. So with that, I'll conclude. Really happy to take any questions. Thank you for everybody for staying on, and hope this was interesting and certainly relevant to your clinical practice.
Thank you, Ajay. Phenomenal lecture. And we have a few minutes, so I can start us out. There's one question, but I think we're going to cover that in some of the questions I may have. So we have 4 minutes. So I think let's focus on ischemia trial, because I think you went through a lot. There's a lot we can talk about, but I think the that is the trial of the day. And I want to ask you a question about the spontaneous MIs, because we kind of assume that this is sort of something we're going to see. And now that it crossed at 1 to 2 years, and now you see the curve separating, for any other trial, if you had a drug that reduced death in MI at 4 or 5 years, we'd be clamoring for it, right? So why do you think this has been something that people have really just not gravitated towards? Is there something wrong with our field that we feel that death in MI in this particular situation is not important enough, but we might see it as important in other areas?
No, I just think that it has to do with just the way, I don't know. That's why I showed that cartoon slide from the very beginning. It's in this milieu of we're doing too much, we're doing too much, we're doing too much. And so then it's more convenient to sort of not have to deal with the fact that that's what the trial results showed. Now, admittedly, if you look at the overall Cox proportional hazard p-value, it's not different between the two arms. But the curves violate the Cox assumption because they're worse up front and then they're better late.
Correct.
So my sense is that I think it's just something we have to have conversations with patients. I've certainly used the ischemia trial, Hari, as you know, to medically manage more patients than I would have before, because I think it's great to have data showing that at least over a shorter period of time, those patients do equally fine and they're not going to drop dead. That's really important. But I do think that some folks do gloss over this reduction in spontaneous MI, which is pretty important when you think it's a group of patients that don't have a lot of symptoms and their EFs are normal.
Yeah, and I think equating procedural MIs and spontaneous MIs obviously is a false equivalency also in terms of the mortality of that or the ramifications of that, or what it means for the patient, similar to angina and medications for the patient versus not medications for the patient. So what do you think about that, the whole aspect of, you showed the landmark analysis that if you get rid of procedural MI, well, how important were the procedural MIs clinically, and are they significant compared to the spontaneous MIs?
Well, clearly, if you have a legit procedural MI, so you're having chest pain, the branch shuts down, and you have EKG changes, and your enzymes go up or your biomarkers go up, you wouldn't want to have that happen, and that's not a good event. But what people also don't realize is that these trials use biomarkers that are ascertained post-procedure to drive that endpoint, and that's actually what drives the increase up front. But in clinical practice, we don't even draw those. We send the patient home. So if this trial had been done like routine clinical practice, it would have shown a dramatic reduction in myocardial infarction, and the primary endpoint would have been in favor of the ischemic arm. So that's why I think it's not, I don't want to dissuade people from collecting clinically relevant information, but if you put it in actual clinical practice and the perspective we have, the trial results are very different.
Right, it would have separated right away. Right, you would have started seeing separation and continued separation with probably a doubling of that benefit, especially because there's a lot of crossover. You mentioned about 30% crossover, which is real world, but that obviously dilutes the results, right? Because some of the, you'll cross over the patients who are having more angina, who are having tighter lesions potentially, and they'll get the benefit.
Nope, fully agree.
Right. So let's see, I think we're at the hour. Did you want to add any other comment?
No, I just really quick in the chat that there was something about improvement of survival. Or the downgrade in survival. As I said in the guidelines, the issue is when you look at all-cause survival, it's harder to sort of hang your hat on a benefit of revascularization, especially because we don't have longer-term follow-up from modern trials. But that's why I really emphasize that reduction in cardiovascular events. because whether they downgrade survival or not is less relevant. If you can reduce MI and cardiac death, that's a pretty important thing for patients. I don't think that there's a question about malpractice and that sort of thing. While we do have to practice thinking about that, I don't like to think about that when I'm dealing with my patients. And frankly, I think the ischemia trial helps a little bit because, as I said, I have a dot phrase in EPIC where I use the ischemia trial to sort of say this: there's not a deleterious effect of treating these patients medically up front, at least for the short term, while they don't have prognostically important disease. So that's, I think, how I want to end it. I just think we have to be better doctors. As an interventionalist, again, I like having an outpatient clinic because it allows me to be grounded, not thinking that I'm just somebody who does technical accomplishments in the cath lab. Hari, I know that's something you believe very strongly in. You see a lot of outpatients as well. And that's why we love the field. So a lot more excitement coming. We look forward to newer trials. And once again, thanks so much for having me. There's a long history of lecturers here, and I hope I did it some justice.
You did a great job. And I do want to thank everybody on behalf of my co-governor, Dr. Vidula, University of Rochester, and of course, your chapter of the New York American College of Cardiology. Please follow us and hope you enjoyed this. This will be available afterwards in edited format, and we'll spread it around on Twitter as well as on our website. Thank you again.
Thanks again, everybody.